to me, it's a moral question. It's an ethical question, because if we don't get under control, we're just putting more and more debt on our children and grandchildren. And that is, I'm pretty sure, wrong.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. Today we have Dr. Len Nichols. We're really glad to have you join our podcast on the business of healthcare. I was fortunate to meet you and hear your keynote address at the annual healthcare conference in Dallas. You were so well received, and your keynote Health Policy 2019 crosswinds and opportunities had everyone engaged. Len, allow me to share with our audience a little bit about your background before we get into our discussion topics. Currently, you're the director of the Center for Health Policy Research and Ethics and professor of health policy at George Mason University. You've been doing this since March of 2010. You've also been a senior advisor for the Office of Management and Budget and a principal research associate for the Urban Institute. You've been intimately involved in healthcare reform debates, policy development, and communication with the media and policymakers for 20 plus years. Your PhD is in economics, so it would be hard not to call you an economist. We're extremely honored to have you join us today, so thank you.
Glad to be here, Bob.
Well, there's too many topics to consider that we could touch with you. So today I'd like to really focus in on the social determinants of healthcare and maybe the larger topic of ethics as well. Is that fine with you?
That sounds good.
Okay. Well, recently, I think last August, you and Lauren Taylor from Harvard, you guys provided policy insight with your paper, Social Determinants as Public Goods, New Approach to Finding Key Investment in Health Communities. This was published in Health Affairs, which everyone knows is a leading journal on health policy research. So since this is the Business of Healthcare podcast, you can't really talk about business without using the words investment and finance. So getting into your paper, leading up to that, Health Affairs had published the relative determinants of overall health back in 4 or 5 years ago, and they said, actually, medical care is only about 10% of the overall health determinant, and behavior was 50%, environment was 20%, and even genetics had a play in it. And since medical care is only 10% of the determinant, these other factors, these social determinants, why don't you expand on their role in determining the overall health?
Well, it's a good lead in, Bob. I would say, you know, what a lot of us do, and it's partly because we spend so much money on that healthcare delivery system part. What part of us do is we focus on how to treat people once they come to us and how to make that treatment more efficient and more effective. But what we're starting to figure out is if we really want to get serious about both making the population healthier and lowering costs, and by the way, those things are correlated, then we're going to have to think upstream. That is to say, think about where people live and work before they get to the healthcare system. And that's really what social determinants is all about. And what's kind of interesting to me as I started thinking about this topic about 1.5 years ago, I just had this sort of intuition that, you know, there's got to be a better way to organize incentives up there, upstream, because it's clear that what we could all do is benefit from investments that are upstream. And by that, I mean making sure more people have access to good housing, making sure more people have access to healthy food, making sure more people actually have a neighborhood where they can exercise and get good, cardiovascular every day. If that were true, then they would come to us less sick and less often. And that would be good for all of us. So a lot of what I was looking for and what came in that paper was how can we find an economic model to incentivize the investment to make sure that we all can gain from this.
So, Len, these social determinants of healthcare programs, you have some examples of those and how they really work?
So let's think about one that most people know about, Meals on Wheels. All right. You know what Meals on Wheels are?
I've helped with that before. It's a great program.
Exactly. What do? We take food to the elderly, typically homebound, or at least, they can't get out as much as they used to. And you make sure that they get good, nutritious meals. Well, turns out, and this is not rocket science, if you give people good, nutritious meals, then they get sick less often, and they can recover from what little deals they've got, and they don't have to go to the hospital in the ER often. So what it's about is getting services to people who would not otherwise get them, which have spillover effects, or what we call, external effects downstream. That is, they improve the health and lower their need to utilize healthcare services. You could also think about housing. There's been some examples of housing first, where, Bob, when you and I were younger, and we started really getting into the business of public housing, people had good intentions, and they said, if you're going to get public housing, well, then you got to prove that you're not an addict of any kind to anything. And that's a sort of a good idea, but then it turns out no one can qualify to get into housing. Housing first is all about, well, look, let's put them in housing first, and then you reduce the chaos in their life so much, you actually can get them more open to dealing with a social worker or a case manager who can help them see the benefit of getting addiction treatment. Next thing you know, you got them in job training. Next thing you know, they're self-sufficient. So turns out housing first interventions for the seriously mentally ill and those with substance use disorder have been shown in randomized clinical trials in US and Canada, lots of different sites, to reduce healthcare costs and criminal justice costs, because after all, those folks interact with the police a lot, reduce healthcare costs and criminal justice costs enough in many cases to pay for the housing. That's what you call win-win.
So, Len, that sounds like such a common sense approach. I recently watched a documentary called The Waiting Room, and it featured a public hospital in California. And seeing the people that came in and the circumstances that they were in, I mean, the emergency room, the waiting room there was their last resort. All these things that you talked about prior to getting there, some of that could have been an intervention. So if this is so much of a common sense approach, why don't health entities invest in these programs?
Well, that is the $64 billion question. But the answer is because these types of services and these types of goods are what economists call public goods. And by that, we mean if you do something upstream, it benefits more than the person who directly paid for it. Let's take a simple example. Imagine in Dallas or Fort Worth where homeless people congregate. And one hospital might, for example, put a nurse practitioner or even a young doc out there in kind of a mobile clinic situation to treat those people. Well, they could pay for that out of the hospital's own budget or whatever, but then they would benefit by having less ED use and less hospitalization to that hospital, but they would also benefit other hospitals. So they can't capture the value of their investment, and as a consequence, compared to the overall potential value, we get way less investment in that stuff than we would otherwise, and that's what we mean by a public good. What my model does, and what we call that problem, is a free rider problem. That is, you have underinvestment because everyone who could invest fears the free riders benefiting from their investment, and therefore they sort of pay for somebody else's benefit. Well, the beauty of the model we've come up with is that that's designed precisely to help solve that problem. Turns out this issue of free rider and public good and stuff like that has been around a very long time. It applies in a lot of different circumstances, not just social determinants of health. And the model was actually developed as a result of folks arguing about a long time ago, we're going toward too much government. We're headed toward too much government. The classic solution in the economics profession point of view to a free rider problem or a public good problem was thought to be by really smart people. Paul Samuelson, Nobel Prize winner and leader of the mid-20th century profession. He said, look, if you've got a public good problem, you're going to have government and you're going to have taxation come in and solve the problem. Well, there were a group of economists who rejected that assertion and said there's got to be a better way. And turns out there is a better way. It was developed in the 60s and 70s by a number of different people. And all I did was go back and look through the literature and find this thing. And then say, hey, you know what? This model is called Vickery-Clark-Groves. VCG for short. This model could be applicable to any public good problem, but particularly in healthcare. Why? Because there are two conditions for the model being able to work. One is there has to be a group of people who would benefit from the intervention, from the activity, who know each other and who kind of share an interest. That is to say, they maybe you've got a stakeholder coalition. You got one right there in Dallas that Baylor Scott White convenes every year called Connecting the Dots, where they get all the hospitals. Parkland comes, all the hospitals come, all the different social safety net providers come, and they really connect to each other and figure out what's going on. So you got to have a stakeholder coalition. Turns out that kind of coalition is being developed all over the country because of two good reasons. One, the penalty that the federal government put in place for readmissions. Right? They wanted to make hospitals try harder to keep people out of the hospital once they had been released. Well, it turns out you can't do that by making it better in the hospital. You got to figure out what's going on outside the hospital, like do they have enough nutritious food? Do they have a refrigerator in which to put their insulin? Do they understand what drug they're supposed to take on Monday as opposed to Tuesday? That kind of low-tech, high-touch stuff really, really matters in keeping people healthy. So first, you got to have a stakeholder coalition that understands there's a common interest. Second, out of that coalition, you've got to have a trusted broker. You've got to have someone to whom the stakeholders would be willing to reveal what they're willing to pay. Now, let's go back to that hospital example. Hospitals don't want to tell other hospitals what they're willing to pay, but they might be willing to tell somebody who's neutral party. And by the way, that neutral party could be a different creature in different parts of the country. In some parts of the country where we've been talking, it might be the United Way. In Texas, it might be one of the big charities. You've got Catholic Charities or Episcopal Health Foundation. It could also be somebody who runs a health information exchange. There's lots of different ways. Academics could do it, Bob. There's lots of different ways you could pull this off. But the point is, you got to have a stakeholder coalition. You got to have a trusted broker. If you have those two things, then you can set up a payment model such that everyone benefits, everyone gains, and then you get the investment and the upstream social determinant stuff that would benefit everyone at a scale that would actually be impactful.
Okay, Len, so this model, without getting too deep into the technical details, at a high level of abstraction, it sounds like the model should work from past experience and modeling ideas. In reality, is this being implemented, and can it work? What's the core action items that need to take place that you might have seen take place already that kind of validates this is a good approach?
So the model's being used. It's interesting. The model's being used now by Google and Facebook and those kind of people, eBay, as they price advertising, because that sort of has similar kinds of spillover effects. So the model's been in place for some time, but it has not been applied to healthcare yet. What we know, Bob, is that we started, my co-author, Lauren Taylor, who's a very smart grad student at Harvard, she'll finish her PhD next year. She and I began talking about this in public in conferences when we get invited to give talks or whatever. And we started talking about it last June. We published our paper in August. And since that time, we've had 15 different communities from around the country, including a couple from Texas, who've come to us and said, hey, we want to try this here. We've got our stakeholder coalition. We think we know who could play the trusted broker role. What we need is for you to come in and teach us how to run the model. So what we're doing right now is we're talking to different foundations around the country, some national, some regional, and putting together coalitions to start this work probably this spring.
Wow, that's quite a turnout from your initial published paper there. I know you've written over 20 articles for Health Affairs, and that is, the peer-reviewed standard out there. So I'm glad to see that people are paying attention to that and making that movement go forward. So congratulations to you and Lauren for that effort. I know that that's a very important part of what you're all about. It's just not publishing, but actually making the world a little bit better, changing the model up.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
Previously, you talked about debt, national debt, and the history of national debt. And like in World War II, our debt exceeded the GDP. And we're in a stage right now where the debt's increasing. How do you see that affecting the whole healthcare future as we move forward?
Well, I put that graph up during my talk there in Dallas last week because I like to remind people that, there's a big underlying reason we need to get healthcare costs under control, and it has to do with our own fiscal structure, our own fiscal stability. We can't be a viable country unless we can pay our debt. And yes, we've been over 100% of our GDP in terms of our publicly held debt, what we owe each other and the Chinese compared to our GDP before we were in World War II. But then we paid it off, as you know, Bob, and basically we brought it down to the low 20% of GDP, and it bounced around a little bit here, there, and yon after that, and now we're headed back toward 100 again. And the difference is back then in the 50s, we had a bipartisan consensus to get our debt under control. And now we don't have that bipartisan consensus. And so while it is technically true that the Affordable Care Act pays for itself in terms of the taxes it raises and the money it's saving out of the Medicare program, basically breaks even with what we're spending for newly covered people. But the overall trajectory of government healthcare spending, I'm talking now Medicare, Medicaid, and all that combined, is the single biggest driving force in our long-run fiscal imbalance. So we're going to probably have to raise taxes. I know that's not popular, but something's probably going to happen. We could do it smartly as opposed to stupidly. We can come back to that. But we're going to have to raise taxes, and we're going to have to get spending under control. And we're going to have to raise taxes less the more we get spending under control. And that's why folks like me and lots of others focus on how can we get healthcare cost growth under control. To me, it's a moral question. It's an ethical question, because if we don't get under control, we're just putting more and more debt on our children and grandchildren, and that is, I'm pretty sure, wrong.
We're actually hosting an ethics workshop here in Dallas at UT Dallas next week for high school students. And I'm really interested in what you're doing with your ethics program at George Mason. Can you give us a little insight on what that covers and the history on it?
Well, our little center here, Center for Health Policy Research and Ethics, was created by a nurse about, 30 years ago or so. And her idea was that we wanted to bring ethical discussions into the discussion of health policy and obviously clinical training, because there's a lot of that goes on here as at your university. But there is no sort of specific ethical curriculum that is required. What we rather do, Bob, is we try to make sure that every course takes into account what you might call notions of equity and notions of political stability, which at the end of the day come down to how you treat your fellow human being. In my own research, in my own work, and in my own courses, I tend to emphasize questions about what sometimes are called health disparities. That is, why is it that we have such different health outcomes across racial and income and ethnic and geographic areas? As you probably know, you can look at any city in our country, I mean any city, and there will be zip codes where the life expectancy is as much as 20, 25, even 30 years higher than the life expectancy of fairly short cab right away. And what are the things that make all that happen? And obviously, as you said at the outset, some of that are choices that people make. But as we learn more about social determinants and all that stuff, we're starting to figure out, well, yeah, choices matter at the end of the day, but choices are often constrained by what's available. Do you have healthy food? Do you have a safe neighborhood? Do you have stress in your life all day long, worried about how you're going to pay for your kids' food, how you're going to get home, keep them safe, and all that stuff. That stress over time leads to a physiological reaction. Cortisol is the technical stuff that comes out. It actually erodes the capacity of your organs over time, and that's partly why these folks die younger. So it's true, odds can be overcome. There are heroic examples every day, but it's also true odds can be changed. And for me, ethics is about trying to make sure that our country has truly equal opportunity for all people. And that means paying attention to what are the things that are holding them back. And some of those things are amenable. Some of those things can be the result of collective investment. We just talked about private sector models that can get you there as well as government. And that's the thing, Bob. We have to get away from depending upon the cavalry or the government to solve a problem. We got to solve these problems at home, where we live, where we work and live and pray. And that's why I'm excited about this kind of work we're doing. I see the desire at the local level in our country to make everything work. It far exceeds the practical level in Washington, D.C., which is why I like to get on a plane and leave.
You know, even in large corporations now, Len, the HR departments, the human resource departments are looking at the stress factor that their employees are encountering. And there's a number of different sources for that, but they're trying to mitigate that. Some of it is financial stress, some of it is, emotional stress, workplace environment, and things of that nature. So I think the ethical component reaches in all directions, not just from a government policy, but from a company policy, from individual work group policies to think about doing the right thing and making sure that people are given the right opportunity to do their very best.
That's an excellent point. I have seen presentations by major corporations where they have figured out that, in fact, the cost of absenteeism and presenteeism, where you're at work but you're not productive, those costs can exceed the actual healthcare costs for many different kinds of diagnoses. And that's why they're starting to pay way more attention to precisely the stress you talked about. But also, let's use those health risk assessments to really probe on some of the dimensions we used to call behavioral or mental. They're all part of the same, and they are, what does the person need to be, as you say, to reach their potential? And I think I feel good about the fact that so many different people are starting to focus in this way.
Well, we have a future view to look at with healthcare. It's an important part of our lives in so many ways. We asked Dr. John McCracken here, John, what do you think the future of healthcare is? And quite often he says, well, the long answer is, I don't know. So what's the short answer? Not really sure. Not really sure what the short answer is. So what's your view, kind of closing things up here on this particular interview, what's your view? How do you see things starting to stabilize in the future in the U.S. for healthcare? What do you see happening? Your personal view on this?
Well, we sort of went through what you might call an existential debate about the role of government. All the debate about the Affordable Care Act, in my view, 85-90% of it was not about health policy. It was about the role of government. And, at the end of the day, that law passed with only Democratic votes, which is unfortunate. And I say that mostly because I know that there were a lot of Republicans back in the Clinton era who were quite happy to propose an individual mandate and to try to use private markets to get more people covered and use subsidies, income-based subsidies, just like this. So I'll just say Obamacare was actually a Republican idea. If you go back to John Chafee and Bob Dole, 1993, it was a Republican idea before it became socialism. So what happened was we allowed this thing to become caught up in the kabuki dance of what's the proper role of government. At some level, the fact that the ACA survived, and now it survived the first 2 years of the Trump administration and a Republican Congress, now we have a Democratic House, the ACA is probably going to limp along, at least for a while longer, which in some ways, you look at the midterm elections, I would submit that more people actually do want people with pre-existing conditions to have access to affordable care than want them to be on their own. And so the question, in my view, going forward is not whether we keep trying to make our healthcare system work for more of us, but how do we do that? And those are questions, Bob, I think we can begin to get serious about. Obviously, it would help if we had better leadership, and we all hope in the coming years we'll get better leadership. But I'm telling you, what I'm heartened by, and I tend to not worry so much about 100 years from now because I'm going to be long gone and smarter people will figure that out. I worry more about 10 years from now. But what I'm heartened by is how many local communities are having these conversations about, okay, what could we do to reduce costs for everybody? What could we do to make access better? What could we do to make sure we don't have so many, low birth weight babies? What could we do to make sure more old people get fed like they should? And they're trying to figure this out, and they're figuring it out in a different way, perhaps in every community. But there's so much creativity because people see, I think, if America's going to work, we have to do it. There is no savior coming. There is no cavalry coming over the hill. We have to do it. Truth is, we've always had to do it. At the end of the day, we have to do this ourselves. And that self-reliance which comes from that can, I think, infuse a spirit of more adult cooperation at the Washington level. So I'm more optimistic than John. I certainly think we have a serious cost problem, but I think we're moving toward a consensus of what we really want to do about that. And what we really want to do about that is figure out how to make it possible for all Americans to have what they need in healthcare, but in a way we can afford it. We actually know how. We just haven't had the political will to do it. And I think we're developing that political will and consensus.
Yeah, I think that's called the American way, and it happens on the local level. So I just want to say, Len, thank you. Thank you for today. This has been a really good conversation. Thank you for the publications that you're doing and for the industries that you participate in. You have a large following, and I know that our audience will benefit from this podcast too, because it's certainly central to what we're all about. So thank you again for joining us today.
Well, thank you, Bob. I appreciate the opportunity, and I'm very glad we sat next to each other there in Dallas.
Okay, very good. Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.